Okay, so we are live now. Assalamu alaikum and good evening to all those who are joining us live through our YouTube and Facebook channels. I will, on behalf of JK Scientists, I welcome you all to our fourth session, which is related to a Talk the Doc series. And today's session is specifically focusing about creating awareness about cancers and the means to prevent it. We are being joined today by two special guests. We are joined by Dr. Abdul Rafeh Naqash and we are joined by Dr. Muhsin Chisti. Dr. Muhsin Chisti is our expert today and Dr. Abdul Rafeh Naqash will be the host and moderator for this session. Dr. Abdul Rafeh Naqash is is working at the Developmental Therapeutics Clinic, National Cancer Institute, Bethesda, and Dr. Muhsin Chisti is an associate professor of oncology at the Oakland University Beaumont School of Medicine. On behalf of JK Scientists, I thank Dr. Abdul Rafeh Naqash and Dr. Muhsin Chisti for being with us today. Dr. Abdul Rafeh Naqash, please go ahead with the session.
Thank you. Assalamu alaikum to all the guests in my live Facebook and everybody else back home in Kashmir, because this session is primarily meant for people back in Kashmir. The mission of Abdul Rafeh Naqash, as Dr. Gul said, which is medical oncologist, main interest early phase clinical trials, which is Bad Shukrguzar, Dr. Gul and his colleagues, ye platform to create Kurmut. JK Scientist platform to create awareness about different issues that we can talk about and inform the people back home. The special guest as Dr. Muhsin Chisti. Dr. Chisti is a son of the soil, which is, I know him from a very long time. MBBS Kurman GMC Srinagar, but residency in Buffalo, New York, and fellowship in Michigan as months. Associate professor at Beaumont School of Medicine, practice in hematology and oncology. Dr. Chisti and Chivaya research the karmas, money yet field response based on their patients, what their patients say and talk about, how they talk about it. The zone as topic show cancer awareness. You show very important topic. Kyaski tu hekiv sochit cancer ch this bemar yus har kaish effect karan in one way or another. Tu agar sochu in the last 5 years, just thinking on the top of your mind, kuita first degree relative, kuita second degree relative, friends, even cancer is either ongoing treatment or it has affected them in one way or another. So, son maqsad az chuki at mutalik thoda kath karo Dr. Chisti sidyam wanan is explain karan is some basic concepts, cancerous mutalik, diagnosis mutalik, yam main goal chuki information heki kashir manslukan yam divishan yi program timan heki benefit karit in one way or another. So, as she pataki cancer to this pemoid, ichin vichan board kush, locked kush, ichin vichan amir kush, garib kush, is a effect kara in one way or another. Tawashi varia important atmutilikim cheese discuss karan regularly. And I'm very glad that you first step numut, and hopefully we can continue this conversation. So Dr. Chisti, Mish pai tashu varia kam karmas tashu varia organizations kam karan. But is karo start it ki used to bozan as kashir maz chahe su scientist I see chahe su aam insan as timan teri fikre ki kya cheez be kya hakavis kare at early detection khadre be prevention khadre, which is very important. So agar toy ka kashir hun toy as kashir mas ka explain karan ek aam insan as ki cancer kya chu to kis par hekir timan kya vanyu timan kya explanation diyo.
Assalamu alaikum everybody. Thank you Rafeh for such a nice and humbling introduction. I think you spoke too much, but anyways, the which is like an oncologist. I practice mainly breast and thoracic oncology in one of the universities at Michigan. The starting like what cancer basically is in very simple terms, cancer is a clone. Cancer is an advanced cell. Yes, you see, survival khatra sari khota zyada kya chu zarurat growth asan. You see, cell change, change, genetic change, kya change, but you start karana clone panun. You see, clone chasan fast growing or it can be slow growing. Magar each nutrients use karan baki cheez and each baki sorry kya path with panun clone paknawan. Growth karan, but damage karan baki sarni structure. So essentially, it's an abnormal, uncontrolled growth of a cell of a particular clone that damages the rest of the structures around it. It could exist as a solid mass, it would have mass chibana, or it could be in liquid form, like you have leukemias. So overall, it's an abnormal growth of a tissue that damages or destroys the rest of the structures in the tissues.
Absolutely. Thank you so much for that explanation. The Yelis Kachikaran about incidents in Kashmir. One or more relatives in the last 5 years, if one just thinks Kanat Kash effect asan gomut what comes to mind, you should do asan sonchan ki Kashmir mas kya chuye winkis epidemic it seems like an epidemic where people are affected so badly, even though asthma's nebrich rozan, we may not hear about it every day, but it's a very big problem Kashmir mas. So tai kya chuvasan ki kya chuye surge or high incidence cancer winkis Kashmir mas. What are your thoughts on that?
First and foremostly, I don't think we have very strong statistics to show that exactly it's higher incident or lower incident. The problem is more grassroots than what we think. Most importantly, advanced cancers or cancers in Kashmir is lack of screening. And I always wonder, not only the third world country, but also Kashmir being really, in conflict for such a long time, healthcare has affected tremendously. So it's not just about the oncology part of it. It's like everything that has been affected. But particularly when we talk about oncology, I think the greatest disadvantage that we have in Kashmir is lack of guidelines, lack of screening tools, lack of screening methods, and overall that concept that you have to go to the doctor only after the diagnosis rather than prevention. I think such a major wajah incidence and prevalence of advanced malignancies is zyada. For instance, I talk to my parents or my relatives. There is something like screening mammogram that you have to do. We use harka advanced country when you at the age of 40 years khatun asan temchi mammogram kanait, right? So by that time, you detect early stages and precancerous lesions and take care of them. Similarly, colonoscopies at the age of 45, when American Cancer Society recommend karan, and the age of 49, as per the US Task Force, colonoscopy recommend karan, PSA detection, and so on and so forth. What do we do in Kashmir?
Absolutely. I think when we a very important point touch you spent Thomas Panis list as much case discuss, but since you brought it up, I think you should very zaruri awareness. I think prevention is better than cure. We learn it at a very early age. And as you mentioned, the fact that colonoscopy, like if you agar survey karo kashin can look on dimension pi colonoscopy kya dimension pi mammogram kya when agar kath karo educated look at dimension pi magar dimension karan ke follow primary reason I think as you touched is primary care doctor like primary care doctor, as you can understand, are very common in North America, Europe as much. Doctor asan, they're the first point of contact is individuals. Establish karan ki kaitin time especially insana screening karan kya test karan after the age of 30 or 40, for example. So that concept and I don't think we can change that immediately. But as you said, awareness is what matters. And Mashiyad, like Pandavari brought us Dr. Guru, Khurshid Guru, the most program started regarding mammogram awareness, creating pamphlets and colonoscopies. And mission Pai status to them, but I think something like that, would be very important to help people understand importance, consequences of not doing it timely, in the future. So I completely agree with you. So another point I was by Assam person ki Kashir must common varia it's a common practice permitted that people marry within their relations. The MCH hereditary cancers first तो I person to explain kare logan khatre ki kya chasan hereditary cancers kya reasons chasan tatmans be kith pait hekin marriages within families hekin problems, hereditary cancer problems more extensive and cause more issues with that.
So before going to that, finishing on the previous discussion, not only the incidence of cancer in Kashmir is not only based on the lack of prevention, but also there are many other factors in Kashmir that have a bearing, like the food, which we will talk. I think we will touch base about that later. The other general practices in Kashmir that we have in, exposure to toxins, which we don't even know, has been in conflict. And I don't know what are the things around in Kashmir, are there radiation emitting things and so on and so forth. The practices of tobacco, chewing tobacco, hookah and all those things. So obviously there are many factors that are actually prevalent that are increasing the incidence and prevalence of cancer in Kashmir. And there are particular types of cancer that are more prevalent than other parts of the world, which has been documented, but not well studied. Going on the genetics part, yes, definitely you brought a very, very important point. Agar he married his cousin. It's very offensive. It's very offensive in Western world. Okay, but they still consider that kind of an awkward old thing belief, other than the those Amish or Mormons. But other than that, yes, this is a problem. This has been well studied in Ashkenazi Jewish population because of the marriages and all. You will see all these genetic cancers are so common in that particular population. This is the same thing when you have a defect in the gene pool, Suchipatagasan transmit into the relationships. Once particular khandan intermarriage varya karan, Patuchuti, not only cancer genes, but also Down syndrome and, many other like autism related issues. It encompasses everything. But particularly in cancer related thing, what we have seen more is, what we have seen more in Kashmir, obviously is the GI malignancies. GI malignancy, what I can tell you, like my grandfather died of stomach cancer. And I get so many consults day in and day out about stomach and esophageal from Kashmir, consults regarding that. So definitely genetics plays a huge role. I think there needs to be a study more relevant to GI and GI malignancies in Kashmir, especially stomach and all. Is there any genetic prevalence? Are there any genes that predispose Kashmiris to this particular cancer? We know, like we study in families here where there's a lot of prevalence of stomach cancer. We check their EC adherent gene and CDH1 or MYH mutations. But I am not sure if anything of that sort has been done in Kashmir.
Right. So just so that, Nazreen and Fikri ki kya mutation kya hai, I just wanted to take like 30 seconds to explain. So agar tumor cha asan, as Dr. Muhsin Chisti mentioned earlier, asan, that's different cells, asan tumorous various cells. Like common notion cho 1 centimeter tumorous much asan 1 billion cells. So take you imagine kiti cells 1 centimeter tumor banawan. Human individual cell and asan different mutations, genetic code asan. Tathil mutation, genetic code is mutation chigasan, alteration chigasan. Achu tumors, different changes ivan tumor badan be hakan blood supply gain kare. Normal tissues exceed in terms of growth. So, Dr. Muhsin Chisti is ki genetics and hereditary. So the concept is ki look upon when they get married and they have kids. Agar husband or wife underlying mutation that is pre-existing brought pachasan, it shouldn't zaruri timanize tumor. Magar yel bachas genes from parents, father and mother, and ye mutation gets predominant, and it can lead to tumors. Even though you may explain a superficial concept, depth is mushkil. But concept you hai ki agar hereditary cancer is look and zyada chance tumor different to get different types of tumors. Screening and talking to their physician, etc. So Dr. Chisti, tachu pani practice months which with hereditary cancers, especially in breast, as to hekvi thoda bahut asmanit BRCA mutation mutlik common mutation to wuchanchu breast months be kis parchi manage karan more in the context of what could be done back in Kashmir rather than what is done in the United States.
So, which was, as I mentioned, I see a lot of breast cancer patients. So, actually, mainly genetic mutations is breast cancer patient, and they are most common one is the BRCA1 and BRCA2. Pachasan, Cowden, the B10. Check mutation, PAL-B. There are many other mutations that we check. Magar, the most common ones that we usually see, BRCA1 and 2. Atmanchi repair phenomenon asan. It's your DNA kis cell gasan thoda defect. That's repair phenomenon, homologous repair phenomenon asan. Yatmansu repair gasan chutu, but you can cell cancerous chan hakan banit kiya. Magar even BRCA mutation valen swak defect asan, swak enzyme asan. Tam sichun su repair gasan kiya. Ilnu su repair go we pachi defective cell bana cancerous. Tam sichu pati not only breast cancer gasan achmanchi varia other baki cancer te hakan gesit. The common ones that happen with BRCA gene are like the breast, ovarian, prostate, the pancreas. The advantage kya cha amich ke agar as pai chu akis family mans ye gene eshikaran so sorry family, we call that person who had the cancer as proband. But them in the family is karan moina asan genetic counseling department, tachasan be a genetist, be asan chu a medical oncologist वगैरह आसान and पच्चीमा family tree बनावन पच्ची उचान तेम्स किमिस कुछ cancer होस बे कत generation मस पच्ची तेमिस इट गसान risk stratification I'm just giving you example of the breast. Then you will see, oh, they had ovarian also, patushan prostate those, patushan pancreatic those. But the tami hisab ch pat guidelines actually imply karanta family pet. Gemi gene as gomu transmit. Temish pati apply kara. For instance, in BRCA, we start screening very early. Timchine pyaran mammograms for the age of 40. They might start at 30, 35 years of age, depending on when the first cancer or how young the cancer developed. Prophylactic mastectomies, prophylactic mastectomies go, they remove once they are done with some childbearing and all, they go for prophylactic removal of the breasts, prophylactic removal of the fallopian tubes and ovaries. Fallopian tubes is more important than ovaries to be removed. That's where the most of the cancer incidence is. Surveillance of pancreatic cancer is higher. We know, I suppose to go to pie, pancreas and BRCA are related, but we have seen now that it's more prevalent. And but prostate, PSA monitoring is much, sooner in people with BRCA mutations. Acha, very important implication treatment was there. BRCA mutation cha asan. Timan cha hakan is when you says research korma time hisab ashushmut you gene repair defects cha asan hago is akipelicit to treat kare. What we call as PARP inhibitors. For instance, agar a patient with BRCA mutation, breast cancer, even in the early stage, you see early stages breast cancer treat kor temches pathawa ikis don variant akpel tachna olaparib. So recently was published Olympia A trial in hisab baso olaparib sapil ak agar yim nen ikis yeah, don't worry in khatr, then the chances survival bada cancer sooner develop kihin. So overall, just talking about BRCA alone, the implications are so far and wide. Use of new therapeutic medications can be done once we know about them. Number one, screening. Number two, treatment. Both are affected by BRCA mutation. Screening should be more aggressive in those families. We don't even know what's the incidence of BRCA in Kashmir. I know many families, just because I'm an oncologist, I get to know, but otherwise there will be much more incidents once we do a good, research about them. Mechuvaria families by breast cancer was trenson generational now. Yeah, the one was prostate, pancreatic. Magar, when I talk to them, somatic, then I mean it's hard. They don't know where to go. There's nothing like a genetics department as such, as far as I know.
Exactly. I was just going to, was ye sonchan geneticists. So yet yim to bozan chiminkes yet US mas ya Europe mas general trend agar patient gets, for example, menishi Dr. Chisti is be is tumor chasan pathologist sozan the pathologist pat wuchan microscope style yeah tumor sozan company there are different companies timan sozan for sequencing, meaning that tumor should assess karan kya mutation kya alteration to tumor mas which is BRCA. The next thing oncologist karan the patient is geneticist, clinical geneticist, the geneticist that patient is kat karan geneticist patient is one kya familial risk kya family mas risk baki bachan as a test karun ya baki hum share and bayan as a test karun. So as far as I know, it doesn't exist in Kashmir, and whoever is listening, on Facebook or wherever, if you are young and if you're into genetics, go for clinical genetics and help people back home and establish a department or establish something that can look oncologists can look and refer it and do a good study of prevalence of these hereditary cancers or mutations back home, which I think is going to add value to the care back home. The Yechak's Sawal, I'm going to touch on them briefly as true. We have a long list of our own questions. The Dr. Chisti, as you would, both of us being from Kashmir, we miss Wazwan a lot, being in the US. So common notion to Wazwan is cheese travan, rang travan ya baki masala asan ya common ethnic foods is kavan che Kashmir mas hagad che kavan ya nunchai che chavan. the notion to thoda role in causing a higher incidence of esophageal or stomach cancers in Kashmir. I know there is no well-established data, and in the Western world, we usually go by data. So what do you think is going on, and what are your thoughts there?
So first and foremostly, what you exactly said, there is no established data. In order to establish smoking's relationship with lung cancer and smoking has a relationship with bladder cancer, there are like prospective and retrospective and cohort studies that have been done tremendously on thousands and thousands of patients. Smoking relationship. Not to my knowledge, this study it's all about demographic studies and all about hearsay and all about associations. What we can say that prevalence the stomach esophageal cancer Kashmir that has an implication environmental genetic food as much. What are the corroborations? Like, why do you think that food would have a role to play? Because we know that there are certain types of carcinogens in certain types of things that we use. Like, for instance, Kabazwan or even other things use sun-dried foods, and we know there's some nitroso amino compounds in them, and those have been associated with cancer. And same thing, there have been a lot of studies on pickles, like, anchar and anchar. There are some studies from other parts of the world as well, which show an association with malignancy. And, why is there a more incidence of cancer in them as compared to other populations? We don't know. We can say there is a chance these are the things that would have an, bearing on increased incidence, but we need definitely a very good study and looking into all other confounding factors that are there. For instance, we know nitroso compounds are there, especially in dried fish. I don't know if that is too much prevalent in Kashmir now. Traditional pickle, NDMA is there, and the quantities that have been seen of NDMA in one of the research papers I was looking at is 7.3 micrograms per kilogram. And in sun-dried food, it's 35 micrograms per kilogram, which is kind of high. And there are other types of nitrosamino compounds and other compounds that could be associated with these malignancies. So the bottom line is, yes, there is something in our food. There is something that is increasing the incidence, which definitely needs a larger study and a very comprehensive study to look into this.
Absolutely. I completely agree. So we have a question, Shiraza Ahmed Choice question regarding PARP inhibitors, but I'll touch on that a few questions down the line when we are at that point, so that, conversation carry on in a smooth, fluid way, going from one topic to another. So one of the questions that comes to mind is, detection. Detection, screening. For a general Kashmiri, for a common Kashmiri viewers, to explain kya process going from detection to treatment. For example, not feeling well, and somehow doctors and doctor is going to find out what is going on with you. Some basic, this is the first step. They're not feeling well, maybe something is wrong, and potentially, it could be malignancy, cancer. The catch steps, basic steps for people back in Kashmir. they can come to a point that cancer detect this and timely treat this.
So detection, but one again, I suppose definitely steps need. The sooner we do, the better it is. I suppose detection definitely preventive aspect to develop in Kashmir. Agar kya possible, I say, using the guidelines from the West, using guidelines from anywhere in Europe or Asia, whatever there are, the set of guidelines to detect them sooner. So detection aspect that is very, very important, and that's where the preventive role comes. I suppose so mammograms to be other modalities, the colonoscopy is common. I'm giving a mammogram and colonoscopy because that's prevalent here. That's what you see in Europe and the West and Americas. Magar michbasam personally, you stomach cancer, esophageal cancer, magbule aam chaite. Time khatra paise guideline starts from somewhere. Start from like maybe it needs more screening than we think about it. Rather than going to a doctor when it's far, advanced, locating those families where it's happening more often, or creating some general consensus in our major institutions like SCIMS or GMC that let's start with more screening of these. Let's have a very low threshold of doing endoscopies in patients, or maybe select an age of like 40, 45 or something like that to do more routine endoscopies to detect these cancers sooner. So detection. So when you talk about detection and prevention, that's a very, very important aspect that we have to further keep on talking about and do something about it as our organization, and helping our brothers back in Kashmir as well with the resources so that they can do it. Yes, to find a ways and means. Population war trod and population poor. The resources to do common things. When prevention endoscopy, it doesn't sink in. It doesn't sink in.
Okay.
Now going through the journey, when, for instance, I'll take an example of an abnormal mammogram. Got you concept abnormal mammogram karno. Breast cancer should detect some patient and pane lump which high once you get but then the patient goes to the doctor, then the mammogram is done. It's not like an abnormal mammogram led to an early detection. It's about a lump that was detected by a patient. That's the most common way of detecting breast cancer in Kashmir. But it's when lump go detect. So the journey starts after a mammogram is done, post detection of a lump by the patient most of the times. Normal patients don't go for a normal routine checkup to their primary care where they could do the breast examinations or anything of that sort, or prostate exams, or even like checking lymph nodes. Nobody goes for a routine. There's no primary care. There's nothing, no concept of that. In fact, when I talk to my father, I'll tell you like, it's what you karun directly he goes to a urologist or directly to a cardiologist for his hypertension. Like, there's no concept of like the prevention.
Bilkul.
So now, yeah, go ahead.
I was just going to reiterate, in Bozan youngsters, I think I say, or Bozan in the next few days, if you have parents who are above 40, if Dr. Chisti stress about screening mammograms, screening colonoscopies. So I pass a parent and relative and one important you should mandatory. It is not something that we are making up right here, right now. It should mandatory because studies, government's aspect, studies involving SARS with patients, which Kuta heki early detection using screening mammograms prevent cancerous, and teach requirement. I think one of the viewers mentioned SCIMS has a very well established oncology department with genetics department, but there is no collaboration. So 1 year, and I will like Dr. Chisti's thought on it. My own intention to discuss this is because the fact is, SCIMS does have a great oncology department. I know some very close colleagues, Zabardast and amazing clinicians, oncologists. The problem is we're talking about an oncology department. We're not talking about a social preventive medicine department, which should be the point of discussion. Yet an early detection happens and they use their resources, government allocated resources, to help in early detection. They might be doing that. You and I are not aware of it in its entirety, but nothing significant that we know of. So when you're oncology department, that means problem has already occurred, and now you're going to an oncologist.
Correct.
So it is not like the problem in the early stage or even before it has occurred. Where it doesn't need to be necessarily treated, using screening strategies, even tumor and early detection karan. So the point is, even though SCIMS or JVC or GMC Jammu or wherever you talk about have very good departments, we need to talk about those departments later down in the stage of this in the journey of cancer for a cancer patient. But early detection is the priority here, and departments like social and preventive medicine or other departments, public health departments, are the ones that need to look into this. So, but first responsibility for Dr. Chisti, it is with the patient or the individual. And as I said, that's why Davichisi session karan in a way so that in the next few weeks, early detection important should be. It's not rocket science. If you have a parent who is above 40, a female above 40, or 45, it's just simple. Go to a clinician and go to a radiologist, get a mammogram done, or go to a gastroenterologist and get a colonoscopy done. It is not that difficult. So that's the point I wanted to make. What are your thoughts on this, Dr. Chisti?
You mean the screening? Which you wanna screening?
You point SCIMS show already. Oncology department. Where does that side of things lag? Is I think the question that is being asked.
We definitely, I'm aware, and I talk to them frequently. Obviously, they're very nice and very helpful people, and they always help me out when if any of my relatives especially is struggling with all those things. They are overwhelmed. These are the only handful that you will know that have to cater to such a huge population. I mean, they go to basic things that they can accomplish rather than doing anything large scale. So that becomes a big issue. Also, the affordability. For instance, you used to Chanchu, UK, US, or European countries, and there's like an insurance thing. Agar drug very expensive, insurance takes care of that. Yeah, government takes care of that. Garib patient lymphoma it's curable. Arch of those rituximab what to do next. So it's more complicated than we can imagine in Kashmir when we go to that grassroots level at cancer treatments and all. But definitely we have we have resources, but they are very handful. They cannot cater to the needs that the whole population needs. Preventive aspects are alag concept. You aggressively develop yet funding yet manpower yet dedicated department
Bilkul. I'm such a internship experience OPDS months that is suspect patient asan GMC Srinagar that look after traveling 5 hours journey for hypertension to the outpatient clinic. His problem preventive aspect I see established at the peripheral centers, because SCIMS should tertiary care hospital. It is not. It shouldn't be your first point of contact. So starting from there, dispensaries and other establishing awareness about screening. It starts from home, and then it starts from your local dispensary, your local hospital, then your district hospital, and then tertiary care centers. So it's a very important concept. Look and understand current key is screening load travel main hospital, but if Dr. Chisti and one them just specialized places. They cater to certain needs. Cater. So it is very important to understand it starts from grassroots level.
Yeah.
Awareness about this is very important.
Yeah, you said it very well. You know, they cannot schemes which are already asan varias, they cannot do screening and all. I mean, that's not up to them. Timan Chasan already, one of my friends was saying how many patients he saw, like, you know, in a day. Like, you know, I start complaining, I can't do it. But when he told me he had to see 70 or something in an OPD, I said, wow. So, and 70 cancer patients is not easy, you know. You're an oncologist. So think about that, you know. I don't know how he does it, but
absolutely no. It should set up to bilkul. So it should set up very Quran, and you know how they practice. We may not necessarily practice like that here, or how we practice here does not apply.
Yeah, for a friend in oncology in Kashmir, for him it's just to get that patient on treatment, get him started. That's the whole goal, and forget about everything else. What caused it? How did it happen? What are his family? It's very hard for him to, you know, when he has to see so many patients and when he has to get through the day and do so much of it on his own. There is no support and everything. It's hard. I really salute all of those colleagues, how they do oncology there. I do.
Absolutely. Yeah. Same thing. You know, I second your thoughts here that Imtitash practice Chikaran, like amazing work based on the resources that they have. This is, you know, very important to understand. Whoever is listening, if agar toichuka patient and the patient doesn't do well, it is not because the doctors did not take good care of him. It is because the system is such that they are overwhelmed. So they have to be, you know, they have to be provided resources. They have to be provided funding. And again, that starts from grassroots level. So it all goes back to basic principles, basically.
The good concept like a nurse navigators. You can't even imagine something of that sort. You know, if a cancer patient go diagnosed with cancer, assign nurse navigator. So nurses you coordinate karun, sorry. Temissary tests arrange karan, temissary, you know, investigations arrange karan, temissary treatment arrange karan. So there's a contact person for that patient. Yusna doctors. You must aram san back and forth karan, and you know, you sorry can help them karan, and that person is very experienced and knows everything, what to do and what not to. The coordination of care is lacking.
Bilkul. So I mean, obviously things are improving. Thoda bahut advancements kasan back home in Kashmir, but we still need time and space to create that awareness that we are talking about. The next sawal to very important sawal kumat Riyaz Shahan, HPV vaccination. We talk a lot about breast and colon cancer, esophageal cancer, but HPV vaccination just chikaran, you know, at the age of 12 or 13, boys and girls. The mission which was HPV vaccination gasam Kashir months. The Twacha information cash system, like what are there any resources that are being used and how important it is?
I know there was some research being done about HPV, role of HPV, human papilloma virus in esophageal and head and neck in Kashmir. There were some people in skims doing about it. I'm not aware that the result, and it was more demographic study than anything else. But yes, we know HPV has a role in certain malignancies, head and neck, and probably esophageal. Maybe it's very relevant in Kashmir actually, and also the GU malignancies. The problem is, you know, again, I'm not aware if that vaccination is being done or being, you know, I'm not aware of that. I have to ask my.
I think again, I apologize. Explain current viewers ki kya HPV cash problem cash karan. So HPV virus and certain viruses, as we know based on research, they have causation or association with certain cancers. HPV being one, human papilloma virus, EBV or Epstein-Barr virus being another one. Beitishvaria viruses, Sari virus karan like coronavirus cancer karan to the best of our knowledge. But in zitre viruses, common cancers karan, jese asan Dr. Muhsin Manantoi, different types of cancers that HPV karit tavai in Europe, North America, South America, ichu praznamna amut ki agar vaccine chikaran against certain strains of HPV, which I can prevent karit, agar early vaccine chikaran in children, which I can prevent karit. Vaccine usually most of the vaccines have failed to date, like for other cancers, as many people may know. Cancer, different types of cancers, no vaccine has been used, but HPV SOAC vaccine varia efficacy harms against prevention of cancer. So to help with thoda explain karit ki kya chi vaccination perhaps, and kya general opinion yet USS mans ya baki janches vaccine karan kya reason ki kit par hai ki prevent karit bhai kya cancer hai ki prevent karit.
So yeah, the USS was basically the vaccine that we use, so Gardasil. So it's more about young women, like in their teenage and so on and so forth. Timanchi vaccination because there are actually 14 most important cancer-causing HPV strains that we know. Mainly important to 16 and 18. They cause 70% of the cervical cancers and precancerous lesions in that have been. It could range from genital warts and so on and so forth. And head and neck especially do that because head and neck cancer is not that common. But what is more important is the vaccination of the young women in their teenage or in their adolescence. That could prevent incidence of cervical cancers, vulval, vaginal cancers, and so on and so forth. Cervical is more important among them. The basic times, you said prevention is karan various common to Western. It's a mandatory thing. Is the Pap smears of women in the childbearing age and thereafter. So Pap smears help in early detection of those woman-related cancers, cervical cancers, and so on and so forth. So not only HPV vaccination, but now we are talking about screening. Pap smears is another thing that's lacking in Kashmir.
Bilkul. And again, it goes back to screening. So, Pap smear, it's not meant for people just specifically in their 40s, 50s. Dr. Muhsin used a very specific term, specific lafaz used, childbearing age. So that makes it very important. Keep the young females, if you're listening or you have a friend who's young female, childbearing age, ask them, Pap smear. And again, it's important because Pap smear smear Nivan microscope style ki kya cells much abnormal cell much, and that triggers certain things, and then you talk to a doctor ki hey me abnormal Pap smear mein kya is karun, and that is why HPV vaccination and these Pap smears are very important in early detection and prevention of certain HPV-based cancers. So, Dr. Chisti, it's great thoda details about some things which I think it's important, given that we got some nice questions.
Rafeh, to be honest with you, when you told me about this is what we going to discuss, I said this is not humanly possible. You either have to focus on screening or maybe detection or maybe treatment. It's a huge.
It could be serious.
Yeah,
it should be serious. So we will request the JK scientist group to hopefully support for subsequent sessions down the line. It's a dialogue, it's a discussion. It is not an education. It is an awareness, obviously. You should not impose but it's a discussion. So it involves discussing common problems, understanding issues, and identifying hurdles to treatment and appropriate care. The Tavai discussion continue ongoing. It does not start and stop here. The common concept to hiki viewers in chemotherapy kya gai. radiotherapy and explain a little bit kith perchi chemotherapy as divan kis waqt some are oral, some are intravenous. Be radiotherapy like common misconception bozan stereotactic radiosurgery issue common like those relatives radiosurgery the atmasha surgery karana to explain basic concept
got it. So I'm not a radiation oncologist by profession, but I'll try to do some justice what I know about it. Radiation on different forms and radio surgery. I want to clear that. That's the concept of the gamma knife. It's like knife without a knife. It's a childhood when you burn the paper with a lens, the sunlight just focus on lens, and then it focuses that on a spot of paper, and that paper burns. So similarly in gamma knife, for instance, there is a lesion in the brain. Use khatam chikarun. So check is machine mas gathan. Radiation travan ek spot spit. Sare converge karan to a spot without damaging the other structures of the brain. So it gives you the precision and also the result as good as 94%, clearing of that lesion, which is kind of like surgery. You're actually like doing a surgery, but not removing it. You're killing the cancer in the place rather than, removing the cancer. So that's why this concept came like a gamma knife. Like it's a knife. You're doing a surgery like a surgery, but not a surgery. Stereotactic surgery, lungs, SBRT stereotactic, that you select the spot in a very high intensity beam that burns that spot in the lung or in the bone or elsewhere or in the prostate. So basically that's what you call it as radiosurgery, not a surgery, but like a surgery. So the other forms of radiation are the traditional radiation. You have area you want to select, but just burn you want. That's different. So prevention like breast cancer patient and prevention radiation. For instance, lump kuruk remove. Magar cancer hai ki wapas se baki breast is. So in order to reduce that incidence, sorry breast 4 to 6 weeks radiate. So that reduces the chance of cancer coming back. That's a prevention of preventive radiation. Another concept is treatment. Treatment stage 3 lung. There is lymph nodes involved. Them lymph nodes burn current. Rest of the lymph nodes are to be burned. So the concept of treatment. Yeah, but go third palliation. Palliation go cancer related pain. So how do you treat that cancer-related pain? You kill that cancer in that particular place. For instance, bone pain. So get palliative radiation. So palliative radiation, treatment radiation, preventive radiation, gamma knife, all these are different modalities. There are new things coming up, like, you have those seeds you implant like in prostate or in breast, things like that. There are new things like tumor treating fields. Zahida advanced. Usually Karan is mainly head and neck cancers, and so continuously a cap like it's various kinds continuously the DNA damage kana cells, and tumor treating fields. So fiduciary concept is coming also in pancreas now. So it's an ongoing research and ongoing concept, but basically to divide it could be preventive, it could be prevention is even done in small cells. Just we know that small cell goes to the brain, preventive radiation to the whole brain is done. So prevention, treatment, palliation.
Bilkul. Thank you so much for that explanation. Again, for viewers, radiation to basically, to should resolve on tumors in a way, concentrate karan beam of radiation and try to kill the tumor. And usually in combination with chemotherapy. Chemotherapy to explain time, but we'll utilize a minute or so for chemotherapy explanation and then go to a couple of other real quick questions.
Okay, I'll try.
This is your test.
Okay. They say brevity is the soul of wit, and that's when I feel that I don't have that wisdom. So, but I'll try. So, chemotherapy used to basically concept. It's a treatment of cancer with chemicals or those drugs that are actually toxins. You see a chemotherapeutic agent, age old from the beginning. Ya to plant derivative asa, ya asan from animal derivative, ya asan from synthetic, from a lab. These are basically poisons. So you titrate these poisons to the amount that a body can tolerate and kill the fast growing cells. So they are toxins. So that's why they are different than the other drugs. Other drugs may not be toxins, but they are toxins. So in real term, if you think about chemotherapies, they are toxins that are titrated to kill the fast growing cells. They could have other toxicities that could be toxic to heart. It's but anthracycline, and they could have toxicities to nerves, but neuropathy. They could have toxicity to other things, blood, bone marrow, cells, blood. So some of them are anthracyclines, some of them are taxanes, some of them are topoisomerases, enzyme inhibitors. So there are so many things and varied mechanisms that they have. Some of them intercalate in the DNA and kill the cell by, inhibiting the, mitosis. Some of them stop the growth. They are like cancer static, like they, they stop the cancer cells from growing. The new concept away from chemotherapy is the immune modulation and the target modulation. When we talk about cancer treatment, it's chemotherapy, immunotherapy, and targeted therapy. Targeted therapy, concept, you have a lock and you find a particular key to that. It's put chronic myeloid leukemia. That's translocation gasam BCR ABL. So you have a drug known as imatinib, dasatinib, or a similar drug that stops that, proliferation, that inhibits that, and then that disease is in remission. It's a wonder of science. Similarly, you have targeted drugs for now tens and hundreds of things, which has changed the paradigm shift of how we treat cancers. As Rafeh is done a lot of things in lung, they have these pills that are way more efficacious than chemotherapy. So targeted drugs are the drugs that have a particular target. That is the cancer-causing target that inhibits them, stops them, or blocks them, and then the cancer is in remission. The third concept that we have in oncology, which is the new and which is the most fascinating and fantastic, for which Nobel Prize was given to a couple of them in 2018, is the immunotherapy. So immunotherapy has changed the paradigm shift of cancer altogether. Lung cancer patients that used to live 1.5 years now are 7 years, 8 years out. Similarly with the GI and colon and all those things. So in immunotherapy, just to give a very simple concept, you chuck antibody on body which works through programmed cell death 1, PDL1, and because we know some tumors have this PDL1 ligand, so them interactions which you train T cells. So the body's own immune system is trained to kill cancer cells, which has a long-lasting effect on remission, like we see in melanomas, like we see in lung cancers. So the bottom line is chemotherapy is just one aspect, and which is smaller aspect now as compared to targeted therapy and immunotherapy. So when somebody gets diagnosed with stage 4 cancer, we look for these targets because we know if we have a target, we can change the survival. We look for the thing if immunotherapy can be given, because if we find that immunotherapy is an option, that has a long bearing on the survival.
Bilkul.
I tried. Okay.
No, I think you did a great job. I just want to make one additional point that maybe people may not have caught. Some chemotherapies are usually, actually different routes of administration. Chemotherapy, IV, immunotherapy is also intravenous, injection. targeted therapy, Dr. Chisti is is karan PARP inhibitor, say olaparib, for example, so targeted therapy, so oral. The which is vanan yachan lookan ki imbozan these treatments are not just specific to US. Treatments are available in India, some of them in Kashmir also. I know some people who are on PARP inhibitors in Kashmir, even though cost very high, cost is a major issue. US must insurance cover karan, unfortunately karan ke. But if you have a cancer and discussion session, so on, ask your doctor about options for targeted or immunotherapy if that's feasible and appropriate in your case. I think it's worth discussing, and there are India's institutions, AIMS, Baki, Tata, Vada, big institutions, they are available, schemes must available. So talk to your doctor and see if these options are available. The real quick 2 to 3 minutes, although this might deserve a separate discussion in itself. COVID choice winkes varia mushkilat patient and varia mushkilat doctor and who are treating patients because they're exposed to the risk. What is your general approach? You patients you want with cancer to catch it about COVID vaccine and kuta safe kuta zaruri so that this information can be important back home in Kashmir.
So not even to talk about Kashmir. COVID did go with the damage. The cancers that we could have gotten early in US, they got delayed. They were as you already know, by the time they came to our clinics, they were much more advanced stage just because they couldn't do the screen, they couldn't do all that stuff. So COVID, as active cancer patient, we usually want to wait 10 to 14 days before resuming the treatments. Agar COVID vaccine the patients of cancer patient, we highly recommend them, because we have seen that it's once cancer patients get COVID, they might not do that well, especially already immune compromised and all. So we highly recommend COVID vaccination in patients with cancer. However, now the new concept is the booster. Patients immunotherapy chemotherapy timan response to vaccine antibody titer much lower. It was studied in some studies. As efficacious vaccine to 90-94%, they might get only 40% response. So the concept of booster is important in them. In fact, not only 2 doses, they might need a third one.
Bilkul. Why important? Because I have some relatives who are on active cancer treatments, and they've taken both their COVID vaccine doses, and it's very important. And hopefully, the booster aspect of it is clarified back in South Asia as well in time, and they're administered the vaccine. Because we're coming towards the end of this discussion and we don't want to prolong, but I do want to ask you the question that was asked earlier so that you can answer it regarding PARP inhibitors. The question is, how much is the efficiency of PARP inhibitors in case of triple negative breast cancer? So to explain thoda bahut in 2-3 lines ki triple negative kya go, breast cancer kya go, because so viewers mass is aware about triple negative, is PARP inhibitor use a type of cancer response, but maybe some association with BRCA, BRCA.
So basically, use triple negative type breast cancer, it is considered one of the aggressive forms, because unmet need. So type of breast cancer, human hormone pill human Herceptin human target use to prolong survival. Recurrences are much more common. Survival is lesser than other types of breast cancers. But having said that, a lot of research is going into that. A lot of research. Like just unmet need, we can do various other research after triple negative specifically. One thing we have found is in patients that have this BRCA mutation, those are the mutations that those patients usually end up. Many of them do have this BRCA mutation that get diagnosed with triple negative. Interesting cheese too. I don't know, Rafeh, if you do a lot of liquid biopsies. I have been doing early stage breast cancer, and I send them for liquid biopsies, and I end up, diagnosing them with BRCA mutations, and then I send them to genetics. It's like the opposite. So you do liquid biopsy just to find some targets, because now with Olympia A trial, you're able to use olaparib in early stage. So checking early stage breast cancers by liquid biopsies, it shows the BRCA mutation. So
right.
The PARP inhibitor benefits is significant. There are many trials. There's EMBRACA, EMBRACA trial, and Olympia A and Olympia trials, where the PARP inhibitors have been used in advanced breast and ovarian cancers with significant survival benefit. I have to pull up data. I'm sorry, I don't want to give wrong statistics, but there was an overall survival benefit on both trials. Olympia AS there was overall survival benefit. Yes, PARP inhibitor was given as a prevention. Tamoxifen, but you have to have a BRCA mutation, BRCA1 or BRCA2 documented. Then only that will be effective or given.
Bilkul. Atma concept mentioned liquid biopsy. So just for the sake of the viewers, liquid biopsy blood test, asan blood test shows on to a lab, to send out lab, and they should detect kya mutation. Because you put science to advance kasan, instead of taking tumor tissue, now the focus is shifting towards just getting a vial of blood, thoda blood karan many months, and they send that 1 or 2 tubes to a certain lab with the capability of testing those mutations. So it should easier gasan for Dr. Chisti and Wonki, early stage patient, breast cancer patient, they just draw out some blood and send it out, and it's way more easier than putting in a needle and needle trauma under compared to when you put a needle and get a biopsy, which is an invasive procedure. Touch your needle trauma in a complication versus agar blood insan kar thoda both in appropriate tubes and send it out. So it is an important thing that is happening these days. I think the second part of the question was thoughts on combining this PARP inhibitor with antibodies and cytotoxic drugs. So I think you should thoda advance sawal for the audience, but as Dr. Muhsin Chisti will agree, right now I don't think there is much data that has there are trials going on, clinical trials.
There's a little bit, in ovarian we use currently, or pancreatic we use, together.
In maintenance.
In
maintenance, right? So in maintenance is what I was trying to get at. Single, like maintenance, chemotherapy complete, but maintenance must PARP inhibitor divan, like same in ovarian and same in pancreatic and same in breast. So combination of PARP with simultaneously along with chemotherapy has not been approved so far. There are trials going on, but we will not discuss that because it should be on the scope of this discussion. The one last question, I've exceeded the 1 hour limit. Interesting discussion, very important topic. The giving back to the community, and I think this is an ongoing process again. Kith point you, me as an individual, or JK Scientists platform as a group, how can we try to use these resources? For people back home, we can try to educate them, we can try to inform them, right information provide karith, and perhaps guide karith, and whatever assistance is required, guide karith what are the steps that need to be taken for something of this sort to help educate and aware people.
Right. So it's not going to be a role or a thing that can be accomplished by a single organization. Each grassroots level aspect, basically stakeholders, those have to be involved, and we can provide the resources for them. We as per se, me or our organizations, Kashmir, we can only tell them this is how we can do. We can provide them resources, but basically we have to involve our own brothers and sisters in Kashmir to create these things. We can help them create these things. We can give them the resources, but unless and until there's a participation and there is an involvement and there is a passion to do it from there, it's not going to be otherwise possible. We cannot do it on our own. It has to be a mutual collaboration.
It has to be it has to be a community effort, and which is but Shukur Guzar, this is a very good platform that JK Scientists Group has created. Team science is very important, and when you have a platform, your platform for example, did you expand Karan towards not just basic science researchers, but also clinicians. Also, I saw which session about a girl who's going in aerospace engineering. So these kind of things, it's not just medicine that helps advance people back home or youngsters, whoever is listening. It is about team effort, team science, and tissue via asal approach to tissue sari aspects gradually touch Karan. And you don't necessarily have to have just people from US and Europe. It can even be experts from within the Kashmiri situation, because one of the questions I commonly get asked here, Tishu Kath Karan sitting in US, but a lot of those things don't apply to people in Kashmir, which is absolutely true. If I was in Kashmir and, I would think that, hey, we don't have many of these resources. Implement resources. True. So you start from basic level. If you've not learned anything from this conversation, the two things that you should take, as Dr. Chisti stressed, via stress aspect, via explain, screening. Screening is so important. If you are a youngster, you have a parent, you have a relative, you have a friend's mother who is above a certain age, talk to them and find out if they need a screening mammogram or screening colonoscopy. Those are the first things that you can start. A second side problem cater, but we can do one thing at a time, and that's where we start. Sitting here, we cannot treat you, or discussion here is not going to help choose a certain chemotherapy or targeted therapy for you. But sitting here, we can discuss what is important, what is required, and you as an individual, when you're listening to this conversation, can initiate that discussion without talking about too many complex concepts. So that is my message. Anything specific, Dr. Muhsin Chisti, that you want to say?
I think you summarized it very well. I think our focus should start with screening, because once we detect patients early on, that will have a huge bearing on the survival. As compared to late stages of cancer, you're just prolonging days and weeks and months, maybe years, but screening will save their lives.
Thank you so much. I really appreciate it. Shukr Guzar tuhun to it was time on a Saturday. The Maria Mazal Taisit Katpat Karnuk. And thank you so much, JK Scientist Group. Someone agar kahin specific question so email address provide karith. My email is abdulrafeh.naqash @nih.gov, and maybe the scientist group can put it up in their YouTube channel also. Agar a specific question, family member related question, just a general question. Youngsters are very inquisitive, so if they have any questions, we'd be happy to answer. And if you are willing to share your email, that would be kind of great.
So yeah, thank you so much, JK Scientist, and it has been very humbling and a great opportunity to connect with you guys. I did not know about this organization until very recently, so you guys are doing a tremendous job. Keep it up, and you can share my email address with people that need it. It's provided with you guys. So mohsinchisti@yahoo.com. It's my personal email, so feel free to get in touch. And as I mentioned, thank you once again, and I look forward to you guys doing a great job as you are in Kashmir, inshallah. Assalamu alaikum.
And inshallah, yes, thank you so much. There's hopefully more sessions to come. I really appreciate everybody's participation. Take care and
Thank you
have
so
a great
much,
weekend.
Dr. Rafeh and Dr. Muhsin, for being with us today. We are not just happy, we're overwhelmed today having you with us. It was, this session was, I believe that this was one of the best sessions in our series because you just put up everything in so detail and so clearly for the audience that I believe that at least if we do not learn most of the things, but we'll have a lot of takeaways from this session today. So before we wind up, we have Dr. Zahida Kamari with us. She's General Secretary of JK Scientists and she's Chair Communications. Also, she's scientist at Cleveland Clinics, US. So Dr. Zahida Kamari, do you have any concluding remarks and word of thanks for our speaker and host?
Thank you, Dr. Chisti and Dr. Naqash. It's like it's really humbling for us that you always are there whenever we need you. It was very informative session, and we believe that we have to have a few more sessions regarding the treatment options also, and in particular with Kashmir. In here, it's not comprehension that we can compare this system with the system back home, and we feel sad that whatever we have here, it's like Mars, and we are comparing it with Earth. But inshallah, we know that the fraternity back home, the medical fraternity, they are working really hard with whatever resources they have. But this one, we wanted like the prevention. I think we covered a lot today. So next sessions, maybe in future, we will have the options, whatever options they have in back home, and we can give informative sessions about that. And I thank you highly for giving us this weekend, and inshallah, we'll see you soon. Thank you so much.
Thank you so much. Take care.
Thank you so much, Dr. Zahida Kamari. Dr. Zahida Kamari is the lead coordinator of this program, also Dr. Doc series. And we also are thankful to Saima Beg and Dr. Mir Zahur Gul, who have been constantly helping us with this session. They are the core members of JK Scientists. So winding up this session, once again, Dr. Rafeh and Dr. Muhsin Chisti, thank you so much for being with us today. And we hope that we'll have more sessions related to cancer awareness. We have a few more in the pipeline, and I think, inshallah, we'll have more sessions with you. Thank you so much, Dr. Rafeh, and thank you so much, Dr. Muhsin.
Take care. Good office.
Thank you.
Let's go.